Graddy.
Great. Thanks, Jen, for the very nice introduction, and thanks for the invitation to be here. Good afternoon, everybody. I'm going to be talking to you today about the health effects of long-term cannabis use, a high-yield talk on a chronic habit, and we should have plenty of time for discussion at the end, but if people want or need to interject, happy to take those as well. So I have no disclosures. The learning objectives for this talk are first to review the variety of cannabis-related psychoactive products available here in the US and the legal complexity around these products. I'll spend the majority of the discussion talking about chronic adverse health effects of cannabis use, and then define cannabis use disorder and talk about some strategies for management. This is a huge topic, right? Cannabis. And so this is kind of focused for our time here on the following. I'll talk primarily about the long-term use of the natural product. We'll touch on synthetic cannabinoids, but that's not really the focus here. Focus on THC containing products, not CBD only products. And we're not really going to talk about kind of the potential positive health effects of cannabis and marijuana, although we can discuss that after. This will focus on the negative health effects and limit it really to use in adulthood, although a touch on childhood and adolescent use of the substance. So we'll start by talking about what is cannabis, the clinical effects in the acute setting, talk a little bit about epidemiology, go on to discuss the legal landscape both here locally and at the federal level, and then spend some time delving into mostly system-based negative health effects, and talk about, end by talking about cutting back and quitting. So just briefly to kind of set the stage, for the most part, I'll be using the term cannabis. For our purposes, it's virtually interchangeable with marijuana. So cannabis refers to the plant and the plant-based product, and marijuana is really cannabis with a high THC content. We're going to focus on cannabis that does have a high THC content. So it's virtually interchangeable with the term marijuana here. So cannabis has been around for a long time. It's a flowering plant that's indigenous to Asia. It has a lot of uses, as we know, right? Used for initially for its fiber as hemp, for things like rope. There are at least two species of cannabis, sativa and indica, and those are the two kind of psychoactive types of the species. There's a third possible species called Cannabis ruderalis, which has a low THC content, and it's typically used for hemp. But in general, it's usually considered a subtype of sativa. Traditionally, sativa is believed to be the more activating form of cannabis, and indica is more sedating, although the published evidence really doesn't bear out the veracity of those claims. And it's complex, right? So this plant contains a lot of different chemicals. There's at least 100 cannabinoid compounds contained in cannabis, including THC, of which the most potent isomer is delta-9 tetrahydrocannabinol. That's the most psychoactive compound and the one we'll focus the most on today when we're talking about the acute effects and some of the chronic psychiatric effects as well. THC is in a terpenoid class, which is the same family as wormwood, which is the active ingredient in absinthe, other than alcohol. And so it's kind of one of a family of different psychoactive substances that's been used for a very long time by humans because of the euphoric feeling and some of the other effects that it has. And then CBD is another one of the cannabinoid compounds in cannabis, but it's not generally considered psychoactive.
Thank you.
In terms of the pharmacology, so there are two main cannabinoid receptors. There's CB1 and CB2. CB1 is primarily present in the CNS, but also exists in the GI tract. And CB1 activation typically affects the parts of the brain involving memory, motor coordination, and executive function. In the GI tract, it also stimulates gastric secretion, motility, and GI sensation, which is one of the reasons that it's believed that cannabis can increase appetite temporarily. CB2 exists peripherally in the immune system for the most part, and agonism can affect inflammation and immunosuppressive activity in the body. And THC is a partial agonist at both of those receptors. The time course of the effects of cannabis is highly dependent on the route of administration. So for example, if you inhale or smoke cannabis, usually you get a peak concentration in the blood within 5 to 10 minutes that lasts about 3 to 4 hours. And if you orally, if you eat cannabis, it takes between 2 and 6 hours typically to reach peak blood concentration, and that lasts up to 12 hours. Cannabis is highly lipid soluble with a slow half-life. So in particular, in people who are heavy users of cannabis, this is one of the reasons why people for weeks and weeks after their last use of cannabis may continue to have positive urine THC screens, because it slowly leaves the body, although the psychoactive effects, right, have worn off by the time that you finally test negative in a urine drug screen or another drug screen. And then the short-term clinical effects, I think, are pretty familiar to most of us, right? They're not as clearly linked to a single or even a couple receptor activity as some other drugs. So, you know, when we think about opioids, it's fairly clean, right? We think of them acting primarily on the mu receptor, and the clinical activities are all explainable by, you know, their activity there at the opioid receptor. But in general, there are psychological and physical effects, right, with cannabis. So euphoria, the sensation of relaxation and sedation that some people like when they use the substance, increased appetite, as I mentioned before, and impaired memory and coordination. Usually at higher doses is where you see kind of the negative psychological effects of anxiety, paranoia, and in rare cases, hallucinations and delusions are sometimes seen. The physical effects include things like dry mouth, red eyes, orthostatic hypotension, and tachycardia. And the risk of these effects also rises with certain preparations that are higher or more potent in terms of the THC that they contain. So preparations that contain resins, liquids, or edibles often contain higher proportions of THC and are more likely to give you some of those acute psychological and physical negative effects. One of the difficulties about kind of teasing out some of the health effects of cannabis is that there are a lot of different things potentially in it, not only the different kind of types of the cannabis plant, but then sort of the varieties and the potency of those, as well as other things like additives. So there are at least 2 different ways to think about cannabis. One is kind of regulated cannabis versus unregulated cannabis. And while we do have legalized recreational and medical cannabis here in California, we have the 3rd least restrictive cannabis regulations in the country. And that measure is based on things like manufacturing and testing criteria, product labeling, the types of products that are allowed on the market, dose limits, and dispensing practices. And there is no, as we'll talk about in a couple of slides, there is no federal oversight, right, for regulation of the cannabis supply. And that's really left up to the state. So even regulated cannabis is not standard from state to state. And then although sort of there are things put in place, right, regulations put in place that generally make it a little bit safer than unregulated product. And then there's synthetic cannabis versus the natural plant product. So synthetic cannabinoids are designer drugs, some of which you can see here on the shelf, right, often sold at gas stations or head shops. They bind to the same receptors as the plant-based cannabis. And they're usually, the form is actually that they're sprayed onto the plant matter. So it appears like the cannabis plant, but the psychoactive ingredient is actually something that's sprayed on. And so that's things like K2 and spice. You can see some of the other names for synthetic cannabinoids here in the photo as well. So cannabis is used incredibly commonly worldwide. It's the fourth most commonly used psychoactive substance behind caffeine, alcohol, and tobacco. Here in the US, it's the most commonly used federally illicit drug, although at the state level, right, it's legalized in the majority of states now. You know, about a quarter of people 12 and older do report use of cannabis within the past month, as of the last National Survey on Drug Use and Health from 2022. And nearly half of Americans report lifetime use of cannabis. There are increasing numbers of people in their 60s, 70s, 80s, and older using cannabis, but it remains most commonly used among people ages 18 to 25, of which about 40% of people in that age group report use in the past year. And it's estimated that about 7% of people 12 and older have cannabis use disorder, which makes it the third most common substance use disorder behind alcohol and tobacco, and by far the most common illicit substance use disorder in the country. There's also a perception of the health risks associated with cannabis, that it is substantially safer than other substances, including alcohol and tobacco. I think there is a reasonable amount of evidence to suggest that it probably is safer than drinking alcohol and smoking tobacco. However, it is not safe, as we'll talk about, and there are some serious long-term health effects associated, especially with chronic high-level use. This figure is from the same survey, that NSDUH from 2022, and looks at the ways in which people have used cannabis over the last year in 2022. So you can see of those who use cannabis, right, most of them are smoking it, close to 80%. About half are reporting oral ingestion of cannabis, and then smaller amounts vape it, dab it, and use it by other
seems like it, right?
modalities. So what is dabbing? Not everybody may be familiar with that, but dabbing is involves heating a concentrated THC extract, so that's hash oil, and then inhaling the vapor. This delivers a much more highly concentrated dose of THC than smoking. And what you can see here in this photo is just some examples of the different dabbing concentrates or oils that people will use. And typically this is unregulated supply. For the most part, this is not regulated legal cannabis. As I mentioned before, the legal landscape of cannabis here in the US is somewhat complex, right? So cannabis remains classified as a DEA Schedule I substance, which means that there's, at the federal level, according to the DEA, no accepted medical use and a high potential for misuse. So other Schedule I drugs include things like heroin, LSD, and peyote. The current administration has moved to try to reduce the scheduling to Schedule III. So US HHS recommended this change based on their review of the available evidence last year in August. HHS is not the body that actually makes that designation. It's the DEA. It's a separate entity. And the DEA has not yet commented. They report that they're conducting their own review of the evidence to determine whether rescheduling is appropriate at this stage. In December of 2022, there was a big move by the Biden administration to at least expand the ability to research cannabis here in the US. And so they passed this bill that's often known as the Cannabis Research Bill. And what this bill does is it expands the sources of research grade cannabis, among other things. So prior to December of 2022, any cannabis that was used for research purposes here in the US had to come from a single source. And this is a photo of actually the farm at the University of Mississippi. This was written into law that this was the single source of all research grade cannabis here in the US. So it's very difficult to get product from that farm. As you might expect, there's a lot of red tape, and it's just kind of a small area There are a lot of concerns that the potency and the quality of the product is not similar to the widely circulating cannabis that's available for medical and commercial purchase across the states. So this has at least opened the door for better quality research and more research related to the effects of cannabis. And currently, as of February of 2024, there are just under half of the states that allow recreational use, and 38 states currently allow medical use of marijuana. So there's this paradox, right? So this is the most commonly used non-alcohol, non-tobacco drug in the US, but it has very little high-quality evidence regarding the health benefits at risk, at least produced domestically here in the US. With that big caveat, we'll move on to talking about some of the chronic health effects. So start with the pulmonary system, right? This is what I think a lot of people think of when they're worried about their patients who come in reporting smoked cannabis exposure. And so we know that, right, first and foremost, the effects on the lungs depend on how you use it. So if you're using oral cannabis, you're not going to be subject to the same effects, right, as somebody who's smoking it or vaping it or dabbing it. There was a long report commissioned by the National Academy of Science, Engineering, and Medicine that was published in 2017, and a series of systematic reviews and meta-analyses since then that have looked at the potential linkage between smoked cannabis use and long-term pulmonary disease, including COPD. And essentially what they found is that there's low strength evidence that smoking marijuana is associated with chronic cough, sputum production, and wheezing, but there's not sufficient evidence to determine the effect of chronic smoked cannabis use on PFTs and the development of obstructive lung disease. So one of the things across these studies that's noted is that, you know, the study subjects who are included in these research projects included in the systematic reviews had substantially lower cumulative exposure levels to inhaled smoke relative to tobacco users who develop measurable pulmonary effects. So with tobacco, in general, changes to the FEV1 that are irreversible occur usually after 5 to 10 pack years of smoking, although it can vary quite substantially. But for someone who smokes exclusively cannabis to develop that amount of smoke inhalation, they would need to smoke 1 joint a day, which is considered moderate to heavy use for 100 years. And so it's possible, right, that some of this may be that people just cannot smoke enough cannabis to get to the level of smoke inhalation at which they would develop COPD. Another important thing to remember is that, or to recognize, is that, you know, people don't use cannabis alone all the time. So it's often used in combination with other substances, including alcohol. But in particular, many people combine tobacco with cannabis to create a spliff. So tobacco can be used, you know, to bulk up the product. And in some cases, for the combined clinical effect. And then at other times, the tobacco leaf, right, cigar papers are used to actually roll cannabis into a blunt. And so if that's the case, right, someone is inhaling both tobacco smoke and cannabis smoke. So this kind of points to the importance of taking a detailed history, right, really knowing when you're talking to your patient about their substance use, you know, how they're using it. And in this case, if they're smoking cannabis, how they're preparing their cannabis, because that can affect both their risks for some long-term health conditions, but also might impact the way that you elect to treat them, right? Whether you're going to offer them something like nicotine replacement therapy in addition to treatment for the cannabis use disorder. And then contaminants are common across both regulated and unregulated cannabis supply, and they likely are contributing to some increased risk for other toxicities. And so, you know, fungus has been isolated in some dispensary source products, so some legal cannabis products, including aflatoxins, which are known to be carcinogenic, heavy metals, and in particular cadmium. has been found in some regulated and unregulated cannabis, and that's a result of fertilizer uptake from the soil in the cannabis as it's growing. And then pesticide contamination is also common, including in legalized products. So while there's no conclusive and consistent links between these contaminants in cannabis and widespread health issues, there are case reports that exist. And in general, again, with the big caveat that state to state regulation varies, regulated product does tend to be safer and has more guardrails than the unregulated product. So one of the things that we often think about, right, and I certainly think about in my patients who use drugs, and in particular people with who are using things like using heroin, pills purchased off the street, stimulants like cocaine and methamphetamine, is that fentanyl adulteration is becoming increasingly common. Especially here in Los Angeles, we've seen rising numbers of fentanyl-related unintentional overdose deaths, particularly among young people. And so there's this fear, right, or it's a question of whether cannabis can be adulterated with fentanyl. And the short answer is probably not. We're probably not going to see fentanyl-adulterated cannabis. And there's a few specific reasons for that. One is that when people do smoke fentanyl, but when they smoke it, they're not lighting it on fire. It's actually either in a pipe or on foil that they're heating up and melting a solid product that then vaporizes, and they inhale the vapor, and that's considered smoking fentanyl. So if you burn fentanyl, it's completely denatured. And so when you're smoking marijuana, right, that's what you're doing. So similar to, you can't adulterate tobacco with fentanyl because of the same reason. Additionally, oral fentanyl has very low bioavailability, so we don't have like oral fentanyl pills, right? Fentanyl lollipops exist, but they're really using mucosal absorption more than the gut. And for example, for the creation of cannabis edibles, the baking process denatures fentanyl anyway. So it's unlikely that oral administration of cannabis is likely to cause problems if there's something like fentanyl there. And then finally, the e-cigarettes that are used to vape nicotine and cannabis don't reach adequate temperatures to aerosolize or to boil fentanyl. And so for all of these reasons, it's unlikely that we will see cannabis adulterated with fentanyl. One thing that we do need to worry about is the risk of other additives in vaping liquids. So in 2019, in the summer of 2019, there was a sharp increase in a number of different states across the country in ED visits related to e-cigarettes or vaping. A lot of young people were presenting with rapidly progressive shortness of breath and cough, often with nausea and vomiting. Chest imaging was showing bilateral infiltrates. And some of these people became quite sick. There were over 2,800 cases documented, which you can see here, kind of the frequency of cases over the course of August and September of 2019 nationwide, recorded by the CDC, and 68 people actually died. And so this became what's been termed e-valley or e-cigarette or vaping associated lung injury. This entity, almost or about 80% of the people who were hospitalized with this e-valley reported recent use of a THC containing product. And the link between these cases appeared to be vitamin E acetate, which is an additive added to the vaping liquid in these cannabis containing unregulated products. And so this is something that that is certainly important to discuss with patients who are using vaped cannabis, particularly unregulated vaped cannabis, which was the case here. So in terms of psychiatric effects related to chronic cannabis use, we know that from population level studies that the use of cannabis in adolescence and young adulthood is associated with increased rates of schizophrenia and depression, and that association strengthens with heavier use earlier in life. The association appears to have become stronger over time, and there's some speculation that this might be related to the higher potency cannabis products in circulation over the course of the past few decades, although that has, I think there's some question about whether that's actually what's happening. We also know that people who already have psychotic disorders and continue to use cannabis after they have that diagnosis have worse outcomes, including increased relapse of their illnesses, longer hospitalizations, and more severe symptoms. There are a number of different psychiatric disorders that appear to have a bidirectional relationship with cannabis. So, major depressive disorder, bipolar disorders, PTSD, ADHD, and schizophrenia are more common in those with cannabis use disorder. However, cannabis use disorder is also more common in those with those illnesses. And so it's not entirely clear what the relationship is here. And it's certainly not a direct line from cannabis use in adulthood to something like schizophrenia. Accidental injuries are also increased in people who use cannabis, in particular heavy and regular users. So we know that active use is associated with the increased risk of accidental injury while impaired. There are a number of different studies that have shown that impairment with cannabis use approaches that of drunk driving. This is present in products that contain THC and combination THC and CBD products. There are a series of different studies as well across the US, and the figure here is from Canada that show a relationship between cannabis legalization and commercialization and increased risk for traffic injuries and fatalities. So this figure is looking at the rate of traffic-related ED visits. We can see trauma-related ED visits in dark blue, and in orange is all ED visits across Canada, pre and post cannabis legalization. The second dotted line, where we see the market uptick in the rate of trauma-related ED visits, indicates the 2019 when non-medical cannabis was rapidly expanded in Canada. We also know that there's common co-use of other psychoactive substances, in particular alcohol, with cannabis, which contributes additively to this accident risk when you use multiple substances together. And unlike alcohol, right, where we can get roadside breathalyzer tests or have somewhat reliable serum tests where concentration can help to give us an idea of the level of intoxication, cannabinoid level in the breath, in the urine, in the blood does not reliably correspond to the level of impairment or intoxication. And so I think this has been a big difficulty, right, as cannabis legalization has spread. There is no single reliable objective test to identify cannabis intoxication medically or within the legal system. Cannabis hyperemesis syndrome is a rare syndrome that often gets a lot of consideration, but it really does not happen that frequently. It's believed to be a disorder of the gut-brain axis involving the central nervous system, the peripheral nervous system, and the gut. And it's characterized by the cyclical abdominal pain, nausea, and vomiting that occur usually within about a day of the last cannabis use in people who have usually daily heavy cannabis use for at least 6 to 12 months. The presentation is very similar, if not identical to cyclic vomiting syndrome, except that this is associated specifically with cannabis. And if you stop cannabis use, the vomiting goes away. The pathogenesis for this is not entirely clear. But in part, it might be related to the CB1 receptors. So as I had mentioned before, those receptors are implicated in gastric secretion, sensation, motility. And so activation of those things happens acutely in cannabis use, and that has an antiemetic effect in most people. However, chronic use can deregulate or downregulate the CB1 receptors, and that can cause nausea. In addition, capsaicin receptors appear to be implicated here, and they usually help with the antiemetic and antinociceptive pain response seen related to THC, but again, downregulation of those receptors in people who use chronic high amounts of cannabis can actually heighten the nausea and the pain. The management of cannabis hyperemesis syndrome is really supportive treatment and abstinence, right? Abstinence is really the only thing that's consistently been shown to improve long-term outcomes in these patients. There is some evidence that haloperidol as a dopamine antagonist may be effective and tends to be more effective than other standard antiemetics like ondansetron. But also because the capsaicin receptors may be implicated here, there's some suggestion that capsaicin cream for people with abdominal pain may help to reset the downregulation that has occurred related to their chronic cannabis use. So spend the last part of the talk talking specifically about cannabis use disorder. So the DSM-5 criteria for all substance use disorders are identical. So you just replace the word cannabis with whatever substance you're interested in. There are 11 different criteria here, and if you meet at least 2 of them, you have a mild substance use disorder, with those meeting 6 or more, severe substance use disorder. Criteria for substance use disorder in general are really characterized by kind of this pervasive series of effects in different areas of a person's life. So it includes things like failure to fulfill major obligations, persistent recurring social, interpersonal, physical, or psychological problems, missing important activities. And the way that I like to think of this is really, what is the impact of this substance use on your home and work life, relationships, and activities? The risk factors for cannabis use disorder are very similar to those for other substance use disorders, include the frequency and duration of use. So those who use more frequently and heavier are more likely to develop a substance use disorder, with an earlier start of use in life increasing that risk as well. People who have experienced adverse childhood experiences and other traumas in their lives are more likely to have cannabis use disorder. Those with mood and other psychiatric disorders, in particular those that start in childhood, use other psychoactive substances, which is quite common among people with cannabis use disorder, and have a family history of addiction. Cannabis withdrawal typically tends to be mild and self-limiting. It's not life-threatening, right? It's not something that we worry is associated with increased risk of seizures, and is more akin to some of the stimulant use disorder withdrawal that we see. The onset is usually 24 to 48 hours after the last use, with a peak within the first week, and the withdrawal symptoms can last for up to a month. People can get depressed mood, anxiety, restlessness, irritability, decreased appetite, and sleep disturbances. And many of the symptoms do overlap with nicotine withdrawal. So it is important, right, again, to get that good history to determine if your patient is using nicotine-containing products as well, and might benefit from treatment with nicotine replacement and other modalities for their tobacco use disorder. And in general, cannabis withdrawal is managed with supportive and symptomatic treatment. For cannabis use disorder treatment specifically, the mainstay really does remain psychosocial intervention. There's some evidence that brief interventions that employ the principles of motivational interviewing, often in the primary care setting, can be effective in those with at-risk and mild cannabis use disorder. CBT, which emphasizes identification and management of a patient's thoughts, behaviors, and external triggers, can be helpful in motivational enhancement therapy, which is another type of psychotherapy, has also been shown to be helpful in some patients. There are no FDA-approved or well evidence-based medications to reduce use. Unfortunately, right, we don't have something like a cannabinoid agonist that has consistently been shown to reduce the risk of return to use or help to reduce use of cannabis. Even though those substances exist, they have not been shown to be effective. And then other medications that have been studied without consistent effect include N-acetylcysteine, gabapentin, topiramate, and varenicline. As always, it's important to treat other substance use disorders that a patient may have, right? We have other substance use disorders for which we have great medications for addiction treatment, and those should be used as appropriate in those patients. And because of the significant burden of underlying mental illness in people with cannabis use disorder, treating underlying mental illness is key as well. So with management of any person who uses drugs, in particular people with substance use disorders, it's important to approach treatment with a harm reduction approach. And so this is often used, the words harm reduction are often associated with addiction treatment and substance use disorder treatment, but they really apply to much of what we do all day, every day certainly in outpatient medicine, but also many times in inpatient medicine. So harm reduction is basically just, reducing the negative consequences of health behaviors without necessarily eliminating the behaviors completely. So there's this kind of emphasis on incrementalism, working with the patient toward any positive change. If we think about other chronic health conditions that we see commonly, like diabetes and obesity, right? It's very rare for people to completely flip their life upside down and go from drinking 3 liters of soda a day to no soda a day overnight. And similarly, we shouldn't expect our patients with substance use disorders to have kind of these overnight epiphanies that suddenly, transition the way that they live their lives dramatically. So as part of this, right, it's important to, again, screen for and address other substance use disorders, and then discuss safer consumption in the context of cannabis. Thinking about discussing cutting down or eliminating tobacco-containing products if patients are using tobacco in addition to cannabis, using regulated supply, safer supply versus unregulated supply, understanding that no supply is really considered safe at this time, and then avoiding driving and other dangerous activities when using. Also thinking about the mode of use, right? Is this patient smoking? Is this patient vaping? Are they dabbing? Are they using orally? It's not necessarily that, using cannabis oral is safer, because the psychological effects of oral use can actually be substantially more severe than smoked cannabis. And there's a lot of variability in terms of the content of THC in oral product from batch to batch relative to a product that's smoked or vaped, which has a more consistent THC content from batch to batch in general. But just talking holistically to your patient about kind of what the major risk factors are for each mode of use. So at this point, I'll transition to question. I don't have a way of eliciting audience response, but people can certainly type in on the chat or shout out. The STEM is here. A 25-year-old man is seen in clinic for an acute visit for insomnia. He reports severe insomnia for 2 months with inability to fall asleep for 4 to 5 hours after going to bed. He notes approximately 6 months of increased anxiety related to starting a new stressful job. He feels on edge almost all the time and is easily irritable. About 1 month ago, he started smoking marijuana to help calm his nerves and quiet his mind. He is now smoking 2 times daily, but finding minimal benefit to his sleep. He denies any impact of marijuana use on his home or work activities. What would you recommend as the next step in management? Would you add zolpidem 5 milligrams to help him sleep? Refer to CBT for cannabis use disorder? Offer treatment for underlying generalized anxiety disorder? Or recommend he try dabbing marijuana as a harm reduction strategy?
Ryan, do you want to walk us through it?
Sure.
And then please, everyone in the audience, you can see Brandon's directions for MOC credit. This is how you procure that.
Yeah. So the correct answer here is C. And somebody had typed that in. So great job. But so I think a couple of considerations here, right? One is that his symptoms of anxiety, insomnia seem to predate his cannabis use, right? He starts smoking marijuana to calm his nerves. And he does meet criteria for at least mild to moderate generalized anxiety disorder here as well. And so that's kind of in the affirmative why offering underlying treatment for generalized anxiety disorder is correct. We don't know that he has a cannabis use disorder. He has kind of up titrated his use of cannabis from nothing to smoking twice a day now. And he may be on his way to developing a cannabis use disorder. But we don't have enough information, and it specifically notes that he doesn't have any impact of this use on his home or work activities, right, which are important components of substance use disorder diagnosis. Dabbing marijuana is generally not considered a harm reduction strategy, in particular because it's highly concentrated THC and it's usually from an unregulated supply. So there are certainly safer ways to use marijuana than dabbing. And then finally, the zolpidem to help him sleep doesn't really address the underlying anxiety that he has, which seems to be related to some other things going on in his life. So we'll go through take-home points, and then I think we have some time for questions, comments. So the data that's available currently on the long-term health effects of cannabis is limited. In part, it's related to the complexity of this plant, which has over 100 cannabinoid compounds. But also here in the US, there's this complex legal status, which has made it difficult to study in controlled settings. Hopefully that will improve with the new legislation that was passed a couple of years ago. It's important, as always, to take a detailed history, in this case, to elucidate the specific health risks and potentially to guide management decisions. Many of the health risks that are associated with smoked cannabis are associated with concomitant tobacco use, so important to ask in particular about that. Cannabis use disorder is common. It's the most common non-alcohol, non-tobacco substance use disorder here in the US. And then with all substance use disorders, we should really approach this within a harm reduction framework. Respect for the patient's autonomy, and with a goal of an incremental approach to healthy behaviors. So thank you very much. Happy to take questions, comments.
Great. Thanks very much, Ryan. If anybody has questions, feel free to unmute if that's easier. Feel free to type into the chat. Maybe I'll start with a question or two. Oh, hang on. Something popped up in the chat. Lecture about cannabis from a researcher in Buffalo emphasized that baby boomers in particular might not understand that the cannabis they used back decades ago is much lower dose than is available now. Do you agree?
Yeah. So this is like pretty well established that the concentration of THC in cannabis circulating in 2023, 2024 is much, much higher than it was 20, 30 years ago. So I think in particular, if people, and we're seeing increased use of cannabis in people in their 60s, 70s, 80s, and beyond. And so in particular, if those people have not used in a very long time, and now they're trying to use, cannabis for chronic pain or some other condition, it is important to talk to them about, right, the potency. The potency is substantially higher now than it was in the past.
Okay. feel free again. Thank you, Barbara, for your question. Feel free if anyone else wants to unmute or put something in the chat. Ryan, could you clarify one point for me? I think you were saying that cannabis does have some activity at the mu receptor. So I was wondering about possible implications for therapeutic interventions like we have with opioid use disorder, but correct me if I'm wrong. And then we have a hand up too.
Yeah, thanks. So I think I wasn't clear. So there is no activity of cannabis at the mu receptor. The distinction I was trying to draw is that opioids are somewhat clean in that like most of the effects that are clinically significant are related to their activity at a single receptor, the mu receptor. Whereas cannabis does not, although there's CB1 and CB2 receptors, which are the primary areas where these compounds are acting, there are other cannabinoid receptors in the body. And so it's not as clear cut. It's not like with opioids, there's basically activity at primarily a single receptor, which is not the case with cannabis.
Got it. Thank you for clarifying.
Yep.
Peter, do you want to unmute and ask your question?
Yeah, thank you so much. So yeah, thanks for the talk, Ryan. I'm a palliative care physician here at Keck, and a lot of my patients want to try marijuana. They are much older usually, but their goal is commonly to treat appetite, treat nausea and pain, and they don't want to feel high. And I think every time they ask me, which strain should I go for? And I said, I have no idea. And do you have any advice on what I should say to that question? And also, do you have a dose recommendation for 80-year-olds that are usually frail trying it for the first time? Like form wise, do you recommend like a gummy versus vape or what? Anyway, so love your input on how I can guide these patients.
Yeah, I wish I had better answers for you. I mean, those are really important and relevant questions, I think, for a lot of us. But so the research is really bad. As I mentioned, there's kind of like the sativa versus indica, like this idea of what is more activating, what is more sedating, but it doesn't really bear out in the research that exists. There's not a whole, even outside the US, there's actually not a whole lot of high quality research regarding different strains and different ratios of THC to CBD. I think we will see more of this as like the Cannabis Research Act leads to the production of more specific useful like real world data. But I cannot tell you what ratio you should be using or what dose. I think medical cannabis, which I didn't really get into, is sort of a weird place. And like here in California, it's just kind of like you can get certified for cannabis as a patient, medical cannabis, and then you go to the dispensary and the bud tender basically kind of provides recommendations for you, right? But the bud tender is not a medical licensed professional, right? There's somebody who's just working in the shop. And so we're dependent on non-evidence-based recommendations
Right.
that are really based on like individual experience with the use of the product. And anybody who's older and frail with multiple medical conditions, right? Start low and go slow is always the right answer. But I feel bad that I don't have a useful answer for you.
No problem at all. I mean, you're letting me know that I don't have an answer either. So
Yeah.
It's not anyone's fault. We have to wait for the literature to come. So I appreciate that response.
Yeah.
Ryan, what about Marinol? And then Dr. Vasquez has a question, and then there's a comment with about an article.
Yeah. So Marinol for like appetite stimulation, you're talking about?
Well, I guess I was thinking of Peter's question, and maybe that's something he uses already, but I'm not sure how the two compare, basically.
Yeah. So I mean, dronabinol or Marinol doesn't. I don't know if I had the information here, but there's a little bit more information about medical usage of some cannabis-containing products. But yeah, I mean, Marinol doesn't provide the same euphoric effect, but it does. I believe it was studied in patients with AIDS-related cachexia and showed to be somewhat effective. But if you look at like, and this was decades ago, if you look at more recent studies and some of the reviews that have been done, there's really not great high quality evidence to support cannabinoid use for cachexia, at least chronically. It might work in the acute setting. That doesn't mean that on an individual basis, it's not useful, but at a population level, it does not seem to be particularly effective.
Got it.
Yeah.
Thank you for clarifying. Mabel is asking, is use disorder risk equal between edibles and smoking/vaping?
Yeah, so that's a good question. I mean, another area where we don't have a whole lot of data, with the exception that we know that higher dose use of cannabis or of THC containing products tends to be associated with increased risk of cannabis use disorder. So edibles, so like, for example, dabbing probably does have an increased risk of cannabis use disorder development relative to other means of ingestion. Edibles tend to have pretty variable concentration of THC, but in some cases can be quite potent. So theoretically, you might see a slightly increased rate of cannabis use disorder with that, but we just do not have great evidence to suggest that one modality versus another. It's more like what is the delivered dose of cannabis, of THC.
And it looks like the article that was pointed out by Robert actually points out that difficulty and some of the particular maybe risks involved with edibles. So thank you for that reference. Anyone have any other questions? And or please use the last minute or so to type in your information to Brandon with the answer to Dr. Graddy's board style question for MOC credit.
Looks like Matt had a question.
Hey Ryan, thanks for the talk. Just one quick question. With regards to that association with development of schizophrenia and early use of cannabis, was there kind of an upper age limit that the studies looked at? Just so we can get an idea to when we might not be at risk for schizophrenia with the use of cannabis?
Yeah, this is a great question that I can't recall off the top of my head. I want to say like teens, like mid to late teens was the upper limit. I think for sure by 21, you see kind of a decoupling of that relationship. But I think it's late teens, but I'd have to look.
Thanks. That's still very helpful.
Yeah.
Great. Thank you very much, Dr. Graddy. And again, don't forget to type in your information for your MOC credit. Thanks to everyone in the audience, as well as Dr. Graddy, and have a good afternoon, everybody.
Thank you.
Thank you.